Hi, everyone. My name is Mark Yarema. I'm the Medical Director of the Poison and Drug Information Service. It's a real pleasure to be here with you today. As Asim mentioned, I have been asked to give a presentation on a number of toxicology topics to the urgent care groups in the city. I'm one of the urgent care physicians at South Calgary. I've been working there for about 1.5 years. First of all, just before I forget, if anyone has any questions after the presentation is over, please feel free to email me at my Alberta Health Services email address, which is on the main slide right here, mark.yarema@albertahealthservices.ca. I'm more than happy to take your questions and comments. And so I just want to disclose, I don't have any conflicts of interest. I don't have any material, financial interest in any of the products that are being discussed. The other disclosure that I do have, though, is that the thing I like about toxicology and pharmacology is that I like looking at photos and graphs of receptors and ion channels and various things. And so I do have some graphs and figures and tables within this presentation, because I feel that if you understand what happens at the basic cellular level, you can then predict what's going to happen clinically and from a toxicologic perspective, because it does make a lot of sense. And so as a result of a poll that was sent to the South Calgary urgent care physicians, I've been asked to talk about 5 different toxicologic presentations today. So I hope by the end that everyone is able to discuss at least some basic pathophysiology, diagnosis, and management of cannabis hyperemesis syndrome, serotonin syndrome, and how to distinguish that from neuroleptic malignant syndrome, toxicity from various cardiac drugs, so beta blockers, calcium channel blockers, and digoxin, acetaminophen toxicity, and then ethanol withdrawal, and a little bit about ethanol intoxication as well. Before I do that, though, I just wanted to present a slide on what PADIS's approach is for the general approach to the toxicology patients. So we do have our own group of ABCs, and so those are the same as everywhere else: airway, breathing, and circulation. But things get a little bit different when you get to D and beyond. So D stands for decontamination, which means, is the patient a candidate for activated charcoal or gastric lavage or whole bowel irrigation? And as a reminder, lavage is no longer a nursing core competency. So if you decide to order that, you'll likely be shown where the lavage kit is, and you'll have to do that yourself. So just keep that in mind. And elimination refers to things like hemodialysis, urinary alkalinization, like for salicylate, and then multi-dose activated charcoal, which is an enhanced elimination method that helps with drugs that are moved through the enterohepatic recirculation. So things like carbamazepine and phenytoin are examples there, valproic acid as well. And then F stands for find an antidote. And so there's roughly about 30 antidotes that we commonly use and are consulted on as to whether we should use them or not. And then G stands for general management, which we can then translate into the second mnemonic on this page, which is rodeos. And so the general management typically includes restraint, which is physical or chemical restraint, and we always favor chemical over physical. Then making sure the patient's on oxygen, check their sugar, as in dextrose. Examination refers to not only your physical examination, but also the tests that you're going to do for the patient, how long you're going to observe them, and then when are you going to go back and reassess the patient to see how they're doing. That's the serial assessment piece. So with that in mind, let's start with case 1. And these are all real cases. They may have been modified a little bit just to meet the criteria for presentation tonight, but they are all based on real cases. So the first one is a 27-year-old female, is a daily user of THC, and recently traveled to South Africa to visit family. She ate some THC edibles there, and it's not entirely clear, though, where she got them. It sounds like it might have been a little bit questionable, shall we say. And since she ate the edible, she's had these recurrent episodes of vomiting and abdominal pain, which she says are better with hot showers, and subsequently comes into urgent care for assessment because of intractable vomiting and pain. And so a workup is completed, including a negative pregnancy test and a urine dip, just to ensure that there's no hyperemesis gravidarum or pyelonephritis or something like that that's causing the problems. And she ends up getting some IV fluid hydration and antiemetics with some improvement, but she's not back to her baseline yet. And so the consult comes in to pat us asking, is there anything else that can be done to try to help with symptoms? And so this is a very characteristic example of cannabis hyperemesis syndrome, or a CHS. And so in general, the CHS is defined as a syndrome consisting of cyclic abdominal pain, usually in terms of months, and then quite severe nausea and vomiting, and all of the symptoms are in the setting of prolonged cannabis use. In terms of the pathophysiology, I'll just say that this is still a disease that's very much in its infancy in terms of being described. We are seeing more of it in the emergency departments for sure, and getting called a bit about it at PATIS, especially since 2017 when cannabis was legalized. There are several theories that exist. They all have low evidence, and so are still very much theories at this point. One is that delta-9 THC has both emetic and antiemetic properties depending upon the amount of exposure. Cannabinoids by themselves may also decrease GI motility. Chronic THC use can lead to some desensitization of cannabinoid receptors, leading to rebound vomiting. And as a reminder, we have cannabinoid receptors throughout our body, primarily two main types, CB1 and CB2. And there may also be some genetic variation amongst patients to help explain why some people get CHS and some don't. There was a very extensive systematic review that was done about 5 years ago that looked at all the literature at that time to try to help develop some diagnostic characteristics for CHS. And so I just want you to focus on the ones that are in the 90s and the ones that are in the 100 range, because those are the most frequent. So as I mentioned earlier, severe nausea and vomiting for sure, vomiting that occurs in a cyclic pattern over months, symptoms that get better after they stop cannabis, compulsive hot baths with symptom relief, and I have a slide upcoming on that to explain why that happens. And then at least weekly cannabis use. That can vary, of course, but typically it has to be at least weekly. And these are usually young individuals, so it's people under the age of 50 at the time that this onset occurs. And so a bit about why do hot showers help? And so here we go into some of the basic science of this. So within our bodies, we have a receptor known as the TRPV1 receptor, or transient receptor potential vanilloid receptor. And that may be involved in the generation of CHS because this receptor stimulates the release of a compound known as substance P. And substance P is elevated in individuals that are experiencing acute pain, and so it results in increased nausea as well as pain sensations. And heat, in particular temperatures above 43 degrees, decreases substance P release by overstimulating the TRPV1 receptor, and so that there may be an antiemetic effect. And in fact, some individuals may come in with quite red and warm and maybe even scalded skin because they spend so much time in the shower, because that relieves their symptoms. So in terms of management, this is really a stepwise approach, and I have included these bullet points deliberately in order in terms of how to start things. So all patients deserve a trial of fluid rehydration, and because they're vomiting, often need intravenous fluid rehydration with Ringer's lactate. Antiemetics should definitely be tried, and in terms of options, there's really the three big ones: ondansetron, dimenhydrinate, and metoclopramide. In terms of which one to choose, it's really the choice of the clinician. In terms of receptors, though, metoclopramide does make some sense because not only does it have some prokinetic effects within the GI tract, but it also has some dopamine antagonist effects. And that's also the reason why haloperidol is given. So haloperidol, a single dose of 5 milligrams intravenously, can be given if the antiemetics fail. And the reason that haloperidol might work is that one of the thoughts behind the genesis of CHS is the stimulation of THC and cannabinoid receptors, or THC, stimulating not only cannabinoid receptors, but also dopamine receptors, and that resulting in nausea and vomiting. And that may be where the euphoria and potentially the psychosis comes from as well. So in the event that the vomiting is not resolving with antiemetics, then haloperidol is something to consider. The other option that's been studied is topical capsaicin cream, and capsaicin inhibits substance P release. It does have some adverse effects, and because it can cause a burning sensation, sometimes it's enough for the patients to say, I really don't like this feeling, and stop it. So that is something to keep in mind. Now, as you'll see when we go through this presentation, I've listed with each case presentation, there's a slide on what antidotes are available at each urgent care. And so you'll see that each urgent care does have the 0.025 capsaicin cream. And typically the way to apply that would be a 1-inch strip that's applied to the abdomen. So first of all, if you're going to be the one applying it, make sure you've got gloves on. Otherwise, you're going to be the one having a burning sensation and local erythema. And then you just take a 1-inch strip, which is roughly the tip of my finger here. And then you just apply that to the abdomen, and it's often recommended to apply it to the abdomen because that's often where the pain is, and so the feeling of having something applied to the abdomen can actually be quite reassuring for the patient, as opposed to putting it elsewhere like the shoulder or the back, for example. But it literally can be applied anywhere, but it's often best to do it in the abdomen. And one of the things to keep in mind is that the concentration of capsaicin that has been studied in some of the published articles is actually 0.075%, and that concentration is not available in any of the urgent care centers. So if you're going to try to mimic something like that, you may have to use 3 times as much, or 3 tips of the finger, to try to match 0.075%. The other thing that's recommended is to avoid opioids if possible, because it may worsen the gastroparesis that may result in further nausea and vomiting and abdominal distension. So, of course, if they have a reason to be on opioids, that's a different story. But if they don't, then it's often recommended that opioids are not used. The other thing is to reassure patients that the symptoms do typically resolve in about 10 to 14 days. And one of the hardest things for people to hear is that the only current way that we know how to treat this is to tell people to abstain from using THC in the future. And this is one of the hardest things for patients to accept. And so it is important to keep in mind that there may be other reasons that the person is on THC. They may have issues with appetite stimulation or chronic pain or something like that. So there has to be a bit of a risk-benefit analysis done, because simply telling someone to stop THC who's getting some benefit from it for other reasons may be very difficult for them to accept, and it may not actually even be appropriate. So they do need to certainly know about the risk of CHS, but it has to be balanced with the benefits they might be getting from THC use. And so this is that diagram that I was telling you about regarding the antidote availability at some of the different urgent care centers. For CHS, it's a full yes across the board. Each site can do IV fluids. Each site has multiple antiemetics. Each site has haloperidol, and each site, as mentioned, has the 0.025% capsaicin cream as well. So some take-home points with respect to CHS. At this point, the etiology is still unclear. There's multiple theories, but no true conclusion as to what causes it. The main diagnostic characteristics include nausea and vomiting, the cyclical nature of symptoms, again, usually over a period of weeks to months, at least weekly THC use, relief with hot showers, and that the symptoms improve with when THC is stopped. And again, when we went over the diagnostic characteristics, each of these is somewhere in the low to mid to high 90s, or potentially even present 100% of the time. As mentioned, avoid opioids if possible, unless the diagnosis is unclear, or of course, unless they're opioid dependent and they're going into withdrawal. And then one of the other things that I was asked to do was to comment on when would you transfer patients to a higher level of care. And so my opinion on CHS patients is that if symptoms don't resolve with fluids and time and antiemetics and haloperidol and capsaicin, then they really need to go to a higher level of care, in part because if they're spending several hours in urgent care, that takes up a bed in an area where it may be able to be used for somebody else. And if they need prolonged observation, then often the emergency department or even an inpatient unit may be more appropriate for them. But certainly if they turn around after a few hours and they've got good follow-up at home, either through a friend or a caregiver or a loved one, and they've got a family doctor in town and can manage properly at home, then it would be okay for them to go home. But there'd have to obviously be an agreement associated with that. So with that in mind, let's move on to case number 2. So case 2 is a 32-year-old male who is normally on fluoxetine and salbutamol, and took some of his girlfriend's venlafaxine 150 milligram tablets to try to sleep. And 2 hours later, definitely regretted that when he developed decreasing level of consciousness and a seizure. The paramedics were called, and what happened was that the patient was found with a GCS of 7. The patient was tachy and hypertensive, had mydriatic pupils and a temperature of 38 degrees, seized again, and received lorazepam as a result of that. And then is brought into the emergency department about 9 hours post-ingestion, and at this point is hyperthermic with a temperature of 39.1 degrees. And again, it is deliberate that I use the term hyperthermia instead of fever. Typically, toxicologic conditions don't cause fever, they cause hyperthermia because there's a difference in the genesis of a fever versus a hyperthermic patient. One involves the hypothalamic set point, another one does not. This patient is tachycardic, they are hypertensive, the pupils are still large, and the patient has evidence of clonus in the eyes and in the ankles. There's lower extremity rigidity, and the GCS is now 14. The patient gets admitted to the ICU for 24 hours, does end up having rhabdomyolysis, but is subsequently transferred to medicine and recovers okay. And so this is an example of serotonin syndrome. And so I know again that I was asked to provide some background on serotonin syndrome and also compare and contrast with neuroleptic malignant syndrome, which I'll do later in this talk. I just wanted to emphasize right at the beginning that certainly in this generation of physicians, we are far more likely to see serotonin syndrome than you are neuroleptic malignant syndrome. And the reason for that is that the newest generation of antipsychotics, the atypical antipsychotics, are far less blockers of dopamine, or especially the D2 receptor, which has been implicated in extrapyramidal symptoms such as akathisia and acute dystonia and Parkinsonism, and NMS is one of those. So as mentioned, the newer antipsychotics tend to be more blockers of the 5-HT2 or serotonin receptors. So just by far and away, you're far more likely to see serotonin syndrome than you are NMS. That being said, serotonin syndrome, the etiology is typically the addition of a second serotonergic agent to an existing drug regimen, and it can be something as innocuous as someone taking dextromethorphan on top of being on an SSRI, for example. So it doesn't have to be a prescribed medication, but it can also be an overdose of a serotonergic drug. And really the main pathophysiology is the increase in neurotransmission and release of serotonin at 5-HT1A and 5-HT2A receptors. There are at least 7 5-HT receptors, but 1A and 2A are the ones that are implicated the most. And so here's one of these figures that I was talking about earlier that I personally love seeing as a toxicologist and pharmacologist. So bear with me, we'll just go through this. This is taken from a really nice review by Dr. Boyer and colleagues on serotonin syndrome. And it's just to demonstrate the example of serotonin neurotransmission. So up at the top here, we have a presynaptic serotonergic neuron. And again, this could be occurring within the brain. It could be from the brain to the target organ. It doesn't matter. For sake of argument, we can say this is just occurring within the brain. So we've got a presynaptic neuron where the serotonin is made and subsequently stored. And then there's a stimulus of some kind that comes, and the serotonin is released into the synaptic cleft or the intrasynaptic space. And then it binds to the postsynaptic receptor, the 5-HT2A and 1A that I was mentioning earlier, and you end up getting increased serotonin. And so the thing with serotonin is that it's involved in a lot of our bodily functions. It's involved in mood and heart rate and blood pressure and temperature regulation, body movement, and a number of other things. So it actually is quite widespread. And the point is that drugs that are implicated in serotonin can really be divided into 5 main causes. They can increase synthesis, they can enhance release, they can inhibit the reuptake of serotonin, so there's more within the synaptic cleft, they can inhibit breakdown, or they can be direct agonists at postsynaptic receptors. And so again, all of the drugs are pretty much grouped into one of those 5. And so here's some examples, and by no means is this a complete list. So there are some things like tryptophan that are metabolized to 5-HT. There are drugs like amphetamines and cocaine that enhance release of serotonin. There's the SSRIs and others that inhibit reuptake. Drugs like linezolid, an antibiotic often used in the ICU that inhibits breakdown. And then there might be direct agonists at receptors like sumatriptan, for example, that we might use for a migraine headache. And so in terms of diagnosing serotonin syndrome, there's several ways to do that. One is to remember the mnemonic CAN, as in, can you diagnose or can you recognize serotonin syndrome? And so the C stands for cognitive changes, the A stands for autonomic instability, and the N stands for neuromuscular abnormalities. So the cognitive changes, first of all, really can be under the giant umbrella of altered mental status, but often these patients are agitated and they might be hallucinating. And one of the main takeaways about the clinical features of serotonin syndrome, especially in comparison to neuroleptic malignant syndrome, is that serotonin syndrome is a hyperkinetic syndrome. These are people that have hyperreflexia, and they're agitated and they're shivering and they're startling and they jump when you go in and examine them. Whereas neuroleptic malignant syndrome is often described as more of a bradykinetic syndrome, where these patients are often akinetic or mute and they have low deep tendon reflexes. And so getting the antecedent history about what the patient was like prior to getting the elevated temperature and the muscular activity can actually help rule in, rule out various diagnoses. The autonomic instability, as mentioned, is because of serotonin's effect on the autonomic nervous system, and in particular on blood pressure and heart rate. So you can get very labile blood pressure, often elevated, but certainly could be hypotensive as well, but more commonly they're elevated. Hyperthermia, as mentioned, it's not appropriate to refer to these patients as febrile. Typically, the genesis behind hyperthermia is a widespread imbalance between excitatory and inhibitory neurotransmitters, as opposed to a change in the set point because of some sort of external pyrogen like a virus or a bacterium. So it's more appropriate to say that these patients are hyperthermic if their temperature is above 38 degrees. And also antipyretics don't work. They don't fix autonomic instability and hyperthermia. In terms of the other features, patients can be diaphoretic and tachycardic, and they can have mydriasis as well as diarrhea and lacrimation. And then finally, the neuromuscular abnormalities, and these are really key things to look for on examination. One of the most important things is looking for clonus. So for the physicians who are watching the group, if in the group, excuse me, if you recall from medical school, about 2 to 3 beats of clonus at the ankles is normal. So you're looking for more than 3 beats, and that can be both spontaneous and inducible. So spontaneous is that they have clonic movements without you doing anything. So you're just sitting there and watching them, or all you have to do is just lift their leg off the bed. Inducible means that you're actually trying to induce it, so that you're either cocking the wrist back or doing the ankle jerk, and then you get the multiple beats of clonus against your hand. And then opsoclonus, that's also a term for ocular clonus, excuse me, which I have a separate slide describing that, but in particular, what are the eyes doing? And this is not the same as horizontal or vertical nystagmus. And like I said, I'll describe that a little bit more in the subsequent slide. As I mentioned, this is a hyperkinetic syndrome. So these patients are hyperreflexic. They may be shivering, they may be startling. There's often rigidity in the extremities, lower more than upper. They may also be quite fidgety, that they can't sit still. That's akathisia. And there may be tremors. They may have an ataxic gait, and they may seize, although quite honestly, seizures are rare. It's usually just more the myoclonic jerks that happen. And so a little bit about clonus. As I mentioned, it can be in the eyes and the wrists and the ankle. And so I just wanted to share with you on this slide a couple of really helpful YouTube videos and videos from the New England Journal of Medicine that are in the public domain. Excuse me. The videos in particular show a young woman, some screenshots of which you see here, who had overdosed on bupropion, and this patient had evidence of spontaneous clonus in the arms, in the legs, and in the eyes. And so one of the keys with respect to looking for ocular clonus is, again, remember with nystagmus, there's that fast, slow saccadic movement. And whenever you see somebody with peripheral vertigo, and you're looking for BPPV, for example, you see that fast, slow movement, almost like windshield washer movements, or washer wiper movements, excuse me. Whereas with ocular clonus, there isn't that fast, slow saccadic movement, and there may be horizontal, vertical, and even rotatory movements, even within a period of about 30 seconds. It's often described as ping pong nystagmus, because it really is like ping pong balls going back and forth. It looks very involuntary and purposeless and disorganized. And so it is a very distinct feature compared to looking for features of horizontal nystagmus in the setting of peripheral vertigo. So YouTube is a great thing. There are some really helpful videos that help differentiate one versus the other. And so again, just putting all of those symptoms together, we're looking for mydriasis, diaphoresis, agitation, tachycardia, autonomic instability, increased GI activity, and then the neuromuscular findings, so clonus, tremor, and hyperreflexia. In terms of treatment, the management includes the basics, so the ABCs. There's no specific treatment needed for GI decontamination unless it is an acute overdose, in which case many of these drugs bind to activated charcoal, and so that would be appropriate. None of these drugs are amenable to extracorporeal removal like dialysis or alkalinization. They're all very lipophilic or fat-loving. They tend to diffuse out into the muscle and into the fat and into the brain, and so they don't remain within the vasculature. And then I'll talk a little bit in a subsequent slide just about ciprofloxacin and olanzapine, because there are some antidotes, although I will just emphasize at the beginning that time and recognizing the diagnosis and periodic benzodiazepines are what makes these people better. The antidotes are not what cure these individuals. Most of these people get better just with time and supportive care. And so that's where the G of this comes in. Supportive care, withdrawing the causative agent, observation, cooling if the patient is hyperthermic, and then an intravenous benzodiazepine. And later on, when we talk about alcohol withdrawal, I have a slide on the management of various conditions using IV benzodiazepines, and there's a chart looking at the pharmacokinetic properties of the IV benzos as well, so you can If you just be patient a little bit, you'll see a little bit more about benzos later on in the talk. This is that slide I was talking about with respect to serotonin syndrome antidotes. So I just want to emphasize they don't replace supportive care. Cyproheptadine, to start with that one, it's a very weak antihistamine and has a weak anticholinergic effect as well as it's an antagonist at 5-HT2 receptors. So it makes sense. But the point is that the studies that have been done suggest that with mild to moderate cases, those people get better without the cyproheptadine. And so I tend to reserve it for the severe ones where they're hyperthermic, and those are people often going to the ICU. It also has some weak antimuscarinic effects. And so if you're not clear on the diagnosis and you're entertaining multiple possibilities, it's better not to give it because you don't want to make a antimuscarinic toxicity worse. And olanzapine similar. Olanzapine is it's an antipsychotic with 5-HT2 antagonism effects, and it also is very profoundly anticholinergic. And so again, if the diagnosis is not clear, it is better to stay away from using any of these antidotes. So to conclude with respect to serotonin syndrome, in terms of availability, so all of the 4 urgent care sites that responded do have some degree of benzodiazepines. No one has cyproheptadine, and 2 of the 4 sites have olanzapine, both Cochrane and South Calgary. So benzos for sure, and fluids, and then in terms of additional management, if they need to go a higher level of care, that of course would be supported. To close in this area, I just wanted to emphasize some of the differences between serotonin syndrome and NMS. So the precipitant is different. NMS is precipitated by a dopamine blocker, so like, again, the traditional antipsychotics. The time of onset is very different. So with serotonin syndrome, it's typically minutes to hours after adding a second serotonergic agent, whereas NMS is on average about 5 to 7 days, anywhere from 1 to 10. Part of the reason that understanding the antecedent history is important is because by the time people come in with full-blown symptoms, it can be very hard to differentiate them because they can both be rigid, they're both tachycardic and hypertensive, they both have wet skin, and they both have mydriatic pupils. Some of the differences, though, is that the reflexes may be more likely to be elevated with serotonin syndrome, whereas NMS is more likely to have bradyreflexia. And some of the unique features, as I mentioned earlier, is if you remember serotonin syndrome, again, is this hyperkinetic, jacked up, ramped up type syndrome. That'll keep you in good stead because you can look for ocular clonus and shivering and startling. I also have this more extensive slide that shows some of the differences and similarities between some of the other toxicologic hyperthermic syndromes as well. I won't go through all of these in detail, but just know that it's there. And this is a favorite question of mine to ask, what the differential diagnosis is for tox hyperthermia for rotating residents, because it's these 5 plus things like uncouplers of oxidative phosphorylation and thyroid storm, and drug fever and dress syndrome and other cutaneous manifestations of some various drug exposures as well. So dress syndrome, TEN, Stevens-Johnson, and those sorts of things. So that's just a few of them. So some take-home points with respect to serotonin syndrome. Again, remember, it's the addition of a second serotonergic agent or the overdose of one. If you remember that SS is a hyperkinetic syndrome and NMS is a bradykinetic syndrome, the key findings is to look for evidence of ocular, wrist, or ankle clonus. And remember that 2 to 3 beats of clonus in the ankle is normal. So you're really looking above 2 to 3 beats of clonus. And when you see it, you definitely won't forget it. Treatment is largely supportive. So the point being, we don't usually support the use of antidotes like cyproheptadine and olanzapine. They're usually not needed. And the reasons to send to a higher level of care would be if the symptoms don't resolve with fluids or benzos or time, if they're hyperthermic and hemodynamically unstable, if there's no or poor outpatient follow-up, and any of those would be reasons to send to a higher level of care, because once somebody is symptomatic, it's most of the time, the minimum amount of time might be about 6 to 8 hours of symptoms, but most of the time you're looking at least 12 to 24, which is beyond the capacity of urgent cares to keep somebody that long for observation. So if somebody is symptomatic that you're having to actively treat, they probably need to be sent out. So let's move on to case 3, and I've divided this into case 3A and 3B. You'll see why in a minute. This was a patient that I saw in 2010 at the Rocky View. It was a 57-year-old female who intentionally overdosed on multiple medications of hers: bisoprolol, nifedipine, diltiazem extended release, diphenhydramine, and acetaminophen, caffeine, and codeine. And 4 hours post-ingestion, she has 1 or 2 abnormalities in her vitals. Her heart rate is 50. Her blood pressure is a little bit low at 60/40. Respiratory rate 12, but her GCS is 15. And the question is what to do for management. Now, I'll say at the outset that when I'm on call for PADIS, if you want to get a toxicologist's attention, then an ingestion of anything like colchicine, dinitrophenol, or diltiazem would be something that would wake me up out of bed, and I would be fully awake, because these people can get absolutely ridiculously, incredibly sick. So let's go through some of this in detail. This is a beta and calcium channel blocker overdose. And so here we go with a little bit of, again, basic physiology and pathophysiology. I won't go through this in extensive detail, other than to say that this slide is showing normal activity at both beta receptors and calcium channels. And so the bottom line is that when an impulse reaches the myocardium through the SA node, what ends up happening is that the impulse travels down the myocardium. It stimulates the beta cell, which then stimulates adenylate cyclase and increases cyclic AMP. There is then an increase in protein kinase. And what happens is that there is then a release of calcium from the sarcoplasmic reticulum. That is calcium-induced calcium release. And it's that calcium that is then able to then bind to troponin and the actin-myosin complex, and that results in excitation-contraction coupling. And so again, I promise that's about as much as I'll say about that. I'll try to keep it fairly simple, but the point is that there's a real intense interplay, if you will, between beta and calcium channels when it comes to the stimulation of the heart and calcium-induced calcium release. And so not only is the beta cell stimulated as the impulse travels down the myocardium and calcium channels are stimulated, then the calcium channels open, and that's where the calcium influx into the cell then results in the calcium release from the SR, and that's the calcium-induced calcium release. So in the setting of beta and calcium channel blocker overdose, you can just imagine that if you block the effect of beta and calcium channels, then you don't get that stimulation of adenylate cyclase and cyclic AMP, and you don't get calcium influx into the cells, so you don't get calcium-induced calcium release, and you've got a number of things happening that affect that actin-myosin complex, and you don't get proper excitation-contraction coupling. So they don't have very good contractility, they have a low heart rate, and they have a low blood pressure. It's why they get hypotensive and bradycardic. Which leads me into the next slides in terms of signs and symptoms of toxicity. And so one of the things that we often do at PADIS is describe some of the similarities and the differences of beta and calcium channel blockers. So I'm going to go through that in the next few slides here. Beta blocker toxicity looks like mostly hypotension and bradycardia, but some of them can cause, ironically, a tachycardia, because there are some drugs that have what we call ISA, or intrinsic sympathomimetic activity, like acebutolol is an example. They can come in with pulmonary edema or congestive heart failure. There can be nausea and vomiting. They can be hypoglycemic. They can be hyperkalemic, and that's because of the paralysis of the sodium-potassium ATPase pump. So as you might recall, the purpose of that pump is to pump sodium and potassium against their concentration gradients. And so you're trying to pump potassium into the cell where it already has a lot of it. And when you poison that pump, the potassium stays out. That's why they get hyperkalemic. Some of the beta blockers result in altered mental status because they're lipophilic and they diffuse into the brain. And so propranolol is a particular example of that. Same thing, propranolol can cause seizures for the same reason. When you look at that, the same thing with calcium channel blocker toxicity, again, they can be hypotensive and bradycardic. They can be tachycardic, especially the dihydropyridines. So you think of all the drugs that end in pene, like nifedipine, nicardipine, amlodipine. They can have hypotension and a reflex tachycardia because they tend to affect systemic vascular resistance more than they affect the SA and the AV node. The difference is, though, is that calcium channel blockers often result in hyperglycemia. And the reason is because we have calcium channels on our beta islet cells, and the calcium channels are blocked by CCBs. And so the end result of that is that when you don't have calcium influx into the cell, you don't release insulin. And so when you don't release insulin, you get hyperglycemic as a result. And so that's one of the distinguishing features between beta and calcium channel blockers, is looking for evidence of hyperglycemia. The other thing is that altered mental status is much more rare because these drugs are not very lipophilic and they don't cross the blood-brain barrier very well. So you tend to have a normal mental status like this patient did. And so this is one of the key things, is that, as I mentioned at the bottom, the normal mental status can be deceptive because they can look so good because they've vasodilated, they've got warm skin, nice bounding pulses, they're mentating okay, but their core is shutting down. And so they're getting acidosis and renal failure and shock liver. And so just not to be deceived by the fact that they quote unquote look great. And the final thing I'll say is that selectivity is lost in overdose. And what I mean by that is that the dihydropyridines like amlodipine normally affect systemic vascular resistance. So you get hypotension and a reflex tachycardia. And what happens is that the more that you overdose on that drug, you move from pharmacokinetics to toxicokinetics. And what happens is that selectivity where you drop blood pressure and raise heart rate goes away. So you drop heart rate and blood pressure at the same time. And so not to say, well, this can't be a amlodipine overdose because they should be tachycardic. That's simply not true. They can be extremely bradycardic as a result. And so just to summarize some of those differences, so the ones I've highlighted in yellow gold here are the main differences. So altered mental status would be more likely with beta blockers, less likely with CCBs. In the serum glucose is normal or low with beta blockers. It's usually high with most CCBs, mostly verapamil and diltiazem. And then the serum potassium is often normal or high in the setting of beta blocker overdose, whereas it's usually normal in the setting of CCBs. So those are some of the differences. Now, all of that to say that when people overdose on both of them, all of this goes out the window. It's really, if you've got two patients lined up next to each other, one is a beta and one is a CCB, those are going to be some of the differences. But in the real world, they often ingest both. Treatment is a very stepwise algorithmic approach and really could be its own talk. In fact, all of these topics could be their own talk. So I've really tried to condense this down into one slide. In terms of ABCs, sometimes these individuals need to be intubated so you can decontaminate them properly, because there aren't a lot of antidotes that are going to get you out of trouble every time. All of these drugs are bound well to activated charcoal. So if it's an acute ingestion, within the first few hours, I would still give them charcoal as long as their mental status, their GCS is 15, or they have their airway protected. These drugs are not amenable to dialysis, though, except for some of the water-soluble beta blockers. And so there's a mnemonic, either Santa or Satan, which is things like sotalol, inositol, nadolol, timolol, and atenolol are the big five. So you could consider dialysis in those situations. Again, not an urgent care decision. In terms of antidotal treatment, though, I usually teach this to residents and fellows in 4 steps. The first things are the things that you can try, but you don't expect them to work very well because the effects are downstream. So fluid boluses, typically Ringer's lactate, 20 mils per kilogram, usually 2 liters in an adult. Atropine, calcium gluconate or calcium chloride, recalling that calcium chloride has 3 times as much calcium as calcium gluconate, so you need to give 3 amps of calcium gluconate for every 1 of calcium chloride. And the thing with calcium is the rule of 10s, so 10 mils of 10% over 10 minutes. These are not rapid boluses of calcium. It's just, if you remember the rule of 10s, that's a helpful thing. And then glucagon. Glucagon stimulates adenylate cyclase by bypassing the beta receptors. So it's useful for both beta and calcium channel blocker overdoses, but more so for beta. Step 2 would be things like high-dose insulin as an increased inotrope, or norepinephrine or epinephrine. We usually suggest high-dose insulin because in the failing heart, the last thing you want to do is give it a lot of catecholamines and have to make it work harder. You want to actually make it work smarter rather than work harder. Step 3 would be using intravenous lipid emulsion. Step 4 is a transvenous pacer, and step 5 is methylene blue and ECMO. Step 6 is a chaplain in the event that all of these things have been tried and they're not successful. And so you'll see why I went through this a little bit quickly is just because when you put this into the urgent care context, by the time that somebody has failed step 1, or even when you're using step 1, they really need to be transferred out, because urgent care's ability to do anything beyond step 2 is essentially 0. And so just to summarize some of those treatments, just to bring this slide back again, as I mentioned, glucagon can bypass a blocked beta receptor. You can try giving a direct beta agonist, again, like epi or norepi, and just try to stimulate the heck out of that beta receptor. You can also give calcium salts. You're really just trying to overcome a blocked receptor, but that's why many of these things don't work, is that the receptor simply won't let a lot of things in. And that's why there isn't one antidote that's really going to get you out of trouble. And so this is the slide I was referring to with respect to cardiovascular drugs and availability. So in terms of step 1, all the urgent cares have IV fluids, calcium, atropine, and glucagon. When you get to step 2, all of them have epinephrine and norepinephrine. No site has what I would consider high-dose insulin. And high-dose insulin, what I mean by that is that it's a bolus of about 0.5 to 1 unit per kilogram, and then about 1 unit per kilogram per hour. So for a 100 kilogram person, that is an 100 unit bolus and then 100 units per hour. All of the urgent cares who responded have the equivalent of 300 units. So you could give somebody a bolus and maybe a couple hours of a high-dose insulin infusion, and that would be it. Then people would be running out of their stock. The other thing I'll mention as well is that there are now studies that demonstrate that peripheral pressors like peripheral norepi is okay. It can be safe and effective when given with a properly functioning IV. So if your center is more in favor of just some peripheral norepi while you get the patient ready to be transferred, that is okay. Just remember again that catecholamines are the ones that we're a little bit more cautious about, because you're basically making a failing heart work harder. In terms of the take-home points for beta blockers and calcium channel blockers, a reminder that selectivity is lost in overdose. Both can cause hypotension and bradycardia. Calcium channel blockers are more likely to cause hyperglycemia. There's some beta blockers like propranolol that cause altered mental status and wide QRS. No antidote always works. The peripheral vasopressors are okay. And in terms of when to transfer, my suggestion would be anyone who is symptomatic needs a higher level of care, because in our experience, even a elderly patient who just takes an extra day's worth or a couple of days worth by mistake, even those folks are symptomatic for about 24 hours. And so again, clearly beyond the urgent care's ability to try to manage these. Case 3B, in contrast, when we stay with cardiovascular drugs, this is an 82-year-old fellow who has a history of multiple illnesses, comes in with about a week of failure to thrive, is on multiple medications, including digoxin, and he comes in with a heart rate of between 36 to 48. He's got some evidence of congestive heart failure. And the bottom line is that his labs show a creatinine of 282, which is new for him, and an elevated digoxin concentration of 4.3, normal being about 1 to roughly 2.1 or 2.2. And this is his electrocardiogram when he comes in, so kind of a slow junctional rhythm. So this is a case of a patient with digoxin toxicity. This patient actually got a couple vials of Digifab at the Peter Lougheed and was admitted to the ICU and made a full recovery and did quite well. And so I just wanted to emphasize again with some basic science slides, just just how cardiac glycosides work and how DIG causes toxicity. So again, if we've got our myocardial cell here in front of us, we start with an impulse from the SA node, and the main feature of the cardiac cycle to start with is the opening of sodium channels. So sodium comes into the cell, and the cell depolarizes because the cell becomes positive. And then the plateau phase of that is the opening of calcium channels. And so calcium comes into the cell, and that's where that calcium-induced calcium release comes in. And all seems to be well. As the cell repolarizes, what happens is that potassium leaves the cell, and the cell becomes more negative. And so that's how repolarization happens, and the calcium-induced calcium release ends up stopping. Now, what drugs like digoxin do is that they inhibit or poison the sodium-potassium ATPase pump. And so the end result of that is that instead of calcium leaving the cell through this passive calcium exchanger, calcium stays within the cell. And that's why at the end result is that you get that calcium-induced calcium release and increased contractility. And that's why DIG is used as an inotrope, especially for people with AFib and congestive heart failure. And so the problem is that the toxicity of digoxin is that when you continue to poison that sodium-potassium ATPase pump and there's too much calcium in the cell, then the cell starts to become more positive. And as the cell gets more positive and it reaches that resting membrane potential, it gets irritable. And when it gets irritable, it starts to beat on its own. And so that's why with digoxin toxicity, you can get extra or ectopic beats like PVCs and PACs and bigeminy and trigeminy, because the heart essentially is more irritable, and you get this increased automaticity as a result of that. One of the things with DIG, though, is that there is a difference between acute versus chronic toxicity. And so just very quickly to go through this is that with chronic toxicity, that's where you see the classic yellow-green halos, because the DIG diffuses into the brain. So if you remember Van Gogh's painting of Starry Night, that's the kind of an example of what yellow-green halos around objects look like. With acute toxicity, though, it's more nausea and vomiting because there's a lot of upset effects to the GI tract. With chronic toxicity, more CNS symptoms, which are less common with acute toxicity. So an altered patient on DIG might be more likely to be chronic toxicity. In terms of the actual DIG level, they're usually high with acute, but might be therapeutic or moderately up with a chronic toxicity. And again, when you poison the sodium-potassium ATPase pump, what ends up happening is that potassium isn't pumped into the cell, and so you get potassium outside the cell, and it's also poisoning all of these sodium-potassium ATPase pumps in skeletal muscle, so you get a hyperkalemia as a result of that. And the bottom line with dysrhythmias from digoxin is it's basically any dysrhythmia aside from a rapidly conducted ventricular rate. And the reason is because DIG primarily affects the AV node and it prevents rapid conduction. That's why it's used for AFib. So a rapidly conducted ventricular rate would not be something that you would expect to see with DIG toxicity. The other thing is that DIG is far less likely to cause hypotension because of the ongoing inotropic effects. So if you had lined up a beta blocker, calcium channel blocker, and a DIG patient, and two were hypotensive and one was not, the one who was not would likely be the digoxin patient, because they can often have heart rates into the 20s or the 30s, but without hypotension, just because the heart is still contracting because of all of that extra calcium inside. In terms of management, again, I'll go through this relatively quickly, because you'll see when we go to the urgent care site or the urgent care availability, none of the sites have digoxin antibody fragments. So this is really more for education and interest, and especially anybody who does work in multiple sites and in an ED where there is digifab. Again, if you don't and you work in a site that doesn't have digifab, this will be less relevant. But DIG is bound to activated charcoal. So if it is an acute ingestion, we do recommend activated charcoal, and just 50 grams times one dose is enough. Remember that DIG comes often in 0.125 or 0.25 milligrams. So giving 50 grams is more than enough to bind the DIG that's present. Neither dialysis nor alkalinization would be expected to be helpful. And I've just included here some reasons to give digoxin antibody fragments. The main one is that if the patient is hyperkalemic, so if the patient's K is over 5, if they've got evidence of brady or tachyarrhythmias, especially bradyarrhythmias that don't respond to atropine. The more common everyday real world reason that it's given is for the undifferentiated hypotensive and bradycardic patient who's on DIG and multiple medications, and you just want to get DIG out of the equation and see what you're left with, because digifab typically fixes the rhythm in about 20 minutes and the potassium in about half an hour. And the final thing is that the management approach, if you don't use digifab, is to simply hold the DIG, gently rehydrate the patient, and expect that over about 48 to 72 hours, their symptoms will improve as long as they've got enough renal function to eliminate the DIG. So if they have renal failure and fluid management is a contraindication, that would be another reason to use digoxin antibody fragments. If you're going to put them into CHF by giving them fluids, then you shouldn't give them fluids. And so, as I was mentioning earlier, each site does not have digifab, but each site does have activated charcoal. And so again, for any ingestion where it's bound to charcoal, charcoal is appropriate. So my take-home points for DIG is that a reminder that acute and chronic DIG toxicity are different disease processes. There's several different parameters to be concerned about. So the vitals, the serum potassium, the ECG, the creatinine, and the DIG level. Those are the big 5 that we're interested in PADIS. It's less likely to cause hypotension. None of the urgent care centers have digifab. And again, if it's a symptomatic patient where you think DIG might be the issue and they potentially need digifab, then these patients should also go to a higher level of care. Even if you just start the fluid resuscitation, those patients should also have to be transferred as well, because again, this is going to take about 2 to 3 days to settle down. And so with that in mind, let's move on to case number 4. So we've just got case 4 and case 5, and then we'll move on to the Q&A period. So this is a patient, a 49-year-old fellow who presents to the emerge with fever and chills for 4 days. And he reports taking 2 grams of acetaminophen every 4 hours for 3 days for fever and headache. He's got a history of chronic hep C with daily alcohol use and vitals as you see there. And this time I will say he is febrile because it's not related to the acetaminophen. He truly just has a fever. His exam's unremarkable, but he's got a detectable acetaminophen and some abnormalities in his INR, AST, and ALT. And so the question is how do we manage this case? And is this, how do you interpret that acetaminophen level? And is this person a candidate for antidotal treatment? So this is an acetaminophen case, and I just wanted to emphasize by this diagram that most of the acetaminophen that we take is metabolized to 2 non-toxic pathways via glucuronidation and sulfation. About 15% of the time, the acetaminophen is metabolized by our cytochrome pathway to this NAPK toxic intermediate, and this is what can cause liver toxicity. So in the event that we've got a functioning liver, though, what happens is that this toxic intermediate is conjugated and we form a non-toxic metabolite and it's subsequently eliminated. If you've got a Tylenol overdose, though, that knocks out about 70 to 80% of your glutathione, that's when you end up developing acute liver toxicity. In terms of the clinical features, acetaminophen follows a 4-stage process. So the stage 1 in the first 24 hours is typically flu-like symptoms, nausea, vomiting, and anorexia. In very rare cases and massive overdoses, it does cause inhibition of complex 1 within the mitochondrion. See, I knew I would say mitochondrion in there somewhere, powerhouse of the cell. So similar to metformin, it inhibits complex 1, and you can develop a coma and metabolic acidosis. Now, that typically happens with massive ingestions of greater than 500 to 600 milligrams per kilogram, and in the setting of acetaminophen levels at 4 hours that are about 6,000 micromoles per liter, so extremely high. Stage 2 is the apparent recovery stage, where the flu-like symptoms resolve and they may develop right upper quadrant pain because of stretching of the liver capsule. And by this time, it should be clear that they have elevated aminotransferases. So ALT and AST need to be elevated by this time for it to truly be acetaminophen toxicity. Stage 3 is then the acute liver failure stage. So they get coagulopathic and encephalopathic. And if they're going to die, they're roughly going to die around this time. And then stage 4, if they recover from this, they will recover typically over the next couple of weeks. In terms of plotting an acetaminophen concentration, just a reminder regarding using the Rumack-Matthew nomogram. First of all, just remember that the units that we use are micromoles per liter. If you just Google Rumack-Matthew nomogram, you will get a number of American-based nomograms that use different units. Micromedics actually has a nomogram in place, and so you can access that from any AHS computer and plot it on the nomogram in our units, and that's really important. The nomogram was developed for acute single ingestions from between 4 to 24 hours post-ingestion. It's not for repeated ingestions like this patient. This is a repeated supratherapeutic ingestion. And it's also not for just plotting serial acetaminophen concentrations to see if you can stop the NAC before 21 hours. So sometimes we get calls where somebody has, on this nomogram, done serial acetaminophen concentrations, and they're just waiting for that level to cross below this line and then stop the NAC. And that's not appropriate. You actually need to treat the patient until there's no more acetaminophen present. And so this is an example of one of the American nomograms, and I put in red here that 1,000 micromoles per liter, 993 for geeks like me, 1,000 for you, is the level at which you would treat at 4 hours. In terms of management, most of the time ABCs aren't necessary unless it's a massive ingestion. Acetaminophen is, however, bound well to activated charcoal. Acetaminophen is also dialyzable, so if they do have that coma acidosis and a really high acetaminophen of 6,000 at 4 hours, then they need to be transferred to a center with dialysis. Hopefully they're already there. And in terms of antidotes, we can actually consider both N-acetylcysteine and fomepizole as possibilities. Now, in terms of N-acetylcysteine, to come back to this diagram, it has multiple mechanisms. It enhances the sulfation pathway up top. It enhances glutathione, so both as a precursor and as a substitute. And in the setting of a failing liver, it actually improves oxygen transport and hemodynamics. And so it's got multiple mechanisms, and NAC's really the treatment of choice. And we've got our two-step protocol that's now embedded within SCM and Connect Care. Fomepizole is usually reserved for those that have bad acidosis and coma and really high levels. Fomepizole inhibits the metabolism of acetaminophen, and also in those patients that really have that bad acidosis, it may actually help reverse some of the mitochondrial dysfunction. Having said that, though, in terms of availability, fomepizole is not available universally throughout all of the urgent care centers. In terms of the reasons for using N-acetylcysteine, it's usually acute ingestions that you can plot on the nomogram, and so anywhere from 4 to 24 hours. In the setting of the repeated supratherapeutic ingestion, though, you really have to look for evidence of end organ damage, So if there's any elevated aminotransferases or INR, that's really what's more important. And then obviously, if they have acute liver failure with coagulopathy and encephalopathy, then they should be treated as well. And this is what I was mentioning earlier about availability of some of the antidotes. So all the sites have acetylcysteine, only Cochrane has fomepizole, so none of the others do. And we would use it more commonly for toxic alcohol poisoning. And so in terms of take-home points for acetaminophen, a reminder that the treatment nomogram is between 4 to 24 hours post-ingestion. Start NAC wherever possible within 8 hours. For repeated supratherapeutic ingestions, definitely treat if there's evidence of end organ damage. With NAC, the main thing is looking for anaphylactoid reactions. So they look a lot like allergic reactions. The mechanism is just a bit different. And in terms of when to transfer, if you've made the decision to start IV NAC, then they should be transferred to a higher level of care, because most patients will need at least 21 hours of NAC. And again, that's not appropriate to keep those patients in in an urgent care center. The other reason to consider transferring is if you work in a center that's due to close and they happen to need serial testing just to make sure they don't cross the line later on, then those patients should be transferred as well. And the last case I want to go through, and I apologize, should be done, I would say, in about 5 or 6 minutes, and then we can open things up for questions. So case 5 is a 35-year-old female who chronically uses alcohol and cocaine. She had an ethanol binge for the past 2 weeks, and last drink was about 11 p.m. She's found seizing at 7 p.m. or 7 a.m. the next day. EMS is called, and the seizure stops on its own. And then is brought into your center with those vitals. And the question is what to do now? So here we have a case of alcohol withdrawal. And so this is the last of the 5 cases we'll go through. The main thing I wanted to emphasize with alcohol withdrawal is that it's really a balance between excitatory and inhibitory neurotransmitters. And so we commonly think of alcohol as being an agonist at GABA receptors, which is absolutely correct, but that's really only one half of the equation. When we drink a lot of alcohol, what ends up happening is that we stimulate GABA receptors and we get increased GABA, or gamma aminobutyric acid. And so the end result of that are things like sedation and ataxia and coordination, potentially stupor, even to the point where patients are comatose. So it's like a benzodiazepine. This would cause a sedative hypnotic toxidrome. But in terms of alcohol withdrawal, what's happening at the same time is that at the same time as the GABA receptors are being stimulated, there's a separate receptor known as the NMDA or N-methyl D-aspartate receptor that's also being suppressed. And it releases glutamate, which is the main excitatory neurotransmitter in the CNS. And ethanol blocks glutamate's action on these NMDA receptors. And so what happens over time, if you go through these stages, is that as the NMDA receptor gets blocked, it starts to get annoyed. So you start producing more NMDA receptors and you increase the amount and the activities of these receptors. So you move from you start off with a baseline normal, you then end up drinking for a little bit, and so you get intoxicated and sedate from the stimulation of the GABA receptor. What happens over time if you continue to drink those, that you produce more of these NMDA receptors, and then if there's a reason that you stop drinking, then you have uncontrolled excitation again from these NMDA receptors, and that gives you the clinical features of withdrawal and the autonomic instability. And so that goes to this. So there's 4 clinical syndromes: early uncomplicated withdrawal, alcoholic hallucinosis, alcohol withdrawal seizures, and delirium tremens. When I first heard this presentation and saw this slide, the presenter actually said, "This guy in the middle looks like President Clinton." You can imagine the devil just talking to it. "Do it, Bill. Do it. Come on, Bill. Go ahead and do it." Anyway, with all apologies to Clinton and Democrats everywhere. So early uncomplicated withdrawal is the first constellation of symptoms, and that's anywhere from 6 to 24 hours after the last drink. And that's really increased sympathetic overdrive and autonomic instability. So people get shaky, tachycardic, hypertension, sweaty, anxious, and vomiting, but they're still oriented. Step 2 is the alcoholic hallucinosis. And so this is the development of hallucinations. And these can be any of visual, auditory, or tactile. Usually it's often described as visual with organic and auditory with functional, but that's not necessarily true. Again, these patients are oriented, so they might be hallucinating, but if you ask them where they are, the date and time, they can tell you that. And these may be the only things that people present with. It may occur in the absence of other signs of withdrawal. The third one is alcohol withdrawal seizures. And so this can actually occur as early as 6 hours after the last drink or as late as 72 hours. And in general, a alcohol withdrawal seizure is generalized tonic-clonic. It's usually brief. It might be repetitive, but status epilepticus is rare, and a postictal period, if it happens, is very, very short. And again, the seizure can happen before you see anything else. And the final thing that can happen is the named after the Belgian beer, which is delirium tremens. I've never had one. If anyone has, please share in the chat what it was like. I would love to hear that. Delirium tremens, or DTs, is also known as trembling madness, and this is one of the later findings. It's 48 to 96 hours after the last drink. And the key component, other than the autonomic instability, is that these people are delirious. So they have an altered level of consciousness. They're disoriented. And that's one of the things that's worth mentioning, is that not every alcohol withdrawal patient is automatically in DTs. So if somebody says, can you come see this patient, he's in DTs, definitely stop what you're doing and go in, because if they are extremely sick, but they might just be in one of the earlier stages. In terms of general management of alcohol withdrawal, and again, I welcome further discussion about this, the housekeeping issues are these patients often need a lot of fluid rehydration because they've been eating poorly, they have increased sympathetic overdrive and insensible losses. At least 100 milligrams of thiamine, although they might need Wernicke's doses like 500 milligrams. 2 grams of magnesium as needed if their magnesium is low. What I can't emphasize enough is no haloperidol or olanzapine unless there is some underlying psychiatric disorder. No matter how much anyone wants to give it when they're hallucinating, this is really, it's not really necessary to give an antipsychotic. Really, the main thing is benzos, and that's if they're seizing or even if they're not seizing. And then phenytoin is absolutely contraindicated for toxin-induced seizures. It doesn't work. It's not the, it doesn't work on GABA at all. And one of the key features is to ask them, why did they stop drinking? Because there's probably a medical reason underneath. Either they've got pancreatitis or cellulitis or something like that that's precipitating this. And so just in the final few slides, I just wanted to just go through a few things just with respect to benzodiazepines. This slide is actually taken from the Goldfrank chapter on SAME in our ClinPharm and Tox Pearl of the Week. We strongly recommend diazepam as the benzo of choice for alcohol withdrawal. If they're seizing, lorazepam is actually better, but diazepam has 3 active metabolites and a much longer duration of action. And so as long as there's no underlying liver failure where they'll be snowed for days, then diazepam is actually what we recommend. If again they're seizing, then lorazepam or midazolam is more appropriate. But one of the risks with lorazepam is that its onset for sedation is about 20 minutes. And so there is the risk of dose stacking with lorazepam, whereby you give so much that you end up over sedating them because you're giving too much. So we do recommend diazepam. And the final thing I'll say about this is pick one benzo and stick with it. You actually don't gain anything by switching between loraz and midaz and diaz. Pick one and give enough. And as I mentioned, diazepam is what we would typically recommend. In terms of antidote availability, we got yeses across the board. So all of the sites have all 3 of those benzodiazepines. And so, so there's very little concern about not being able to find what you need. In terms of the take-home points for ethanol, a couple of other pearls as well is that for acute toxicity, remember that the elimination rate for naive drinkers is about 3 to 4 millimoles per hour. For chronic, it's faster because of induction, so it's more like 5 to 10 millimoles per hour. Ethanol toxicity can really be thought of as agonism at GABA receptors, so sedation, euphoria, decreased respiratory rate, and sedative hypnotic toxidrome. There are 4 stages to alcohol withdrawal, as mentioned here. We prefer diazepam as the preferred benzo. If benzos don't work, then phenobarbital or propofol would be necessary, and both of those drugs can actually cause opening of that chloride channel without the presence of GABA, so they're more direct agonists, and that's why they work. And in terms of transferring, we suggest transferring withdrawal patients. If they don't improve with fluids, benzos, and a few hours of observation, they should be transferred. If there's poor outpatient follow-up, and certainly if there's something else going on, like if they have an infectious complication or pancreatitis or cellulitis, then they should be transferred in for further workup. So I know that was a lot. We're at 7:18 right now, so it sounds like we'll have about a little over 10 minutes for questions. I just wanted to finish by saying that this is the number for PADIS for Alberta and the Northwest Territories, 1-800-332-1414. One of the things I'll just let people know about is that when you call, you are either speaking to a pharmacist or a nurse. They're all information specialists, which is a unique designation within AHS, but they all have a background in pharmacy or nursing. We have 8 toxicologists who are physicians who can provide consultation as needed. And so if you need that doc-to-doc direct conversation, please don't hesitate to ask the information specialist, can I speak to the toxicologist about this case? And they'll page one of us. And I'll finish by saying that if you enjoyed what you heard and you'd like to get a full day of it, our triennial PADIS conference is going to be happening on November the 4th, 2023. That's a Saturday at the U of C Health Sciences Center, so the Foothills campus. The guest speaker is going to be Dr. John Cole from Minnesota, who is one of the toxicologists there, really big into antidotes. So we're looking forward to having him join us. And there'll obviously be a lot of PADIS speakers as well. So I'll close by saying, I know that was a lot of information. I know it's a lot to digest. Please send me your emails with questions afterwards. It's been an absolute pleasure speaking with you this evening, and I will turn things back to Asim. Thanks for the opportunity.
Thank you so much, Mark. Thank you for presenting today. I gave you this monumental task of presenting on some large topics and asking you to do so in a clinically relevant way, but also do so in a tight timeline. And I know I asked you for a major monumental task, and what you did was incredible. You definitely delivered. I'm sure I speak for everyone when I say that it was packed with useful content and very relevant to our practice in urgent care settings, using our available resources and talking about what we can do in urgent care and when we can transfer patients. So thank you very much, Dr. Yarema. That was very, very helpful. Now we're going to start the Q&A period. And so I'm going to ask everyone to please direct message me if you have any questions. I'm going to start with the first question, which is from Lynette Prediger. And her question was, she was wondering, what are your thoughts on using smelling alcohol pads for the improvement of nausea in cannabis hyperemesis syndrome? And as an aside, is it safe to use this technique for pregnancy-induced nausea?
Good question. Yeah, it's so a few of us, us meaning the PADIS toxicologists, have discussed this, and right now we put it into the can't hurt, might help category. So I think it's a very reasonable option to try, especially at this stage of the game when CHS is still a very young entity, if you will. But we're definitely seeing a lot more of it with the legalization of cannabis in Canada. And in terms of pregnancy-induced nausea, yeah, the short answer is yes. I think it can be tried as well. I don't think that there's nearly not enough ethanol that's absorbed that it would cause a problem, because it's not as if it's repeated exposure during the first trimester, which might put somebody at risk for fetal alcohol syndrome. We're talking about intermittent exposures. It's kind of like giving somebody opioids. You're not giving it on a regular basis. So yes to both, Lynette, great question.
Perfect. I have another question for you. So when it comes to digoxin toxicity, one of the things that can happen is, you mentioned you can get AV blocks, right? Bradycardias, and you can get AV node blockade. And what happens if they go into like 3rd degree block or something more severe? Is there any role for transcutaneous pacing or atropine, or what we can do in urgent care if that were to happen, and with the transfer delays that we live with today?
Of course. Yeah, great, definitely great question. So this is one of those situations where there are some similarities with ACLS, toxic bradycardia, and also some deviations as well. So to expand a little bit on that, the reason that we say, atropine and things like that and fluids are things that you can try but may not help is because with atropine affects primarily the SA node by inhibiting vagal tone, and the disease process with the digoxin is down at the AV node. So you're affecting SA versus AV. And so it's like trying to pump the patient full of calcium in a calcium channel blocker overdose. You can try it, but because the disease process is downstream, it may not work. Same thing with transcutaneous pacing, in fact, even transvenous pacing for that matter, but I'll stick with transcutaneous. What often happens is if you don't fix the underlying problem, you get electrical capture without mechanical capture. So your heart rate might go up to 70 or 80 or so, but essentially you've got this big bag of a heart that is just not contracting particularly well, and so you may not see much an improvement of blood pressure. Having said all of that, recognizing the limitations of what urgent care can and cannot do, there's no contraindications to trying those things. They're not going to make the patient worse. The point is that they're not going to be the most definitive treatments. What those people need actually is Digifab plus or minus a transvenous pacer.
Thank you. That makes a lot of sense. Another question for you is, you had mentioned with capsaicin cream that the dose for most of the studies is 0.075%, but the dose that we have in urgent care available is 0.025%. You had mentioned. So should we use like more of it, or do you use it more frequently? I don't know. Is there any way to counter the fact that you're kind of underdosing?
Yeah, that's a really good question. The simplest approach would be instead of putting 1 inch on the abdomen, is you just do that 3 times at once. This is still an area where I've not been able to find anything that gives you proper dosing recommendations for capsaicin. It's basically apply some to the abdomen in roughly this amount, and and see what happens. So knowing that the concentration is 0.075% in those studies, the simplest thing I think would just be to triple the dose that we would give at the 0.025, and just basically take 3 1-inch strips and apply that to the abdomen. The one thing I will say about the capsaicin, if you're going to try it, is that because of the burning sensation and the irritation, sometimes patients actually can't tolerate that and don't like it. And so you do need to tell them beforehand, this is what might happen. It's similar to gluing a wound, is you have to tell them about 20 to 30 seconds, you might actually get some burning as the glue does its job. And then at least they're not surprised when it happens. So that would be why I would say I wouldn't vault capsaicin over fluids and antiemetics, and maybe not even haloperidol, because the studies are equivocal. But if I had to use it, that would be what I would do with 0.025%.
Perfect. Next question is from Dr. Anthony Cito. The first question he has is, what's the upper limit of safe with regards to the QTC prolongation when you're using Haldol or Haldol in addition to other antiemetics to avoid arrhythmias? Yeah,
good question, Anthony. The short answer to that is 500 milliseconds. And the reason for that is that on websites that study the prolongation of the QT interval on a regular basis, 500 milliseconds is the cutoff at which the risk of torsades increases. Now, at the same time, at the level at 500 milliseconds or greater, the incidence of torsades with all comers of high-risk drugs is about 1%. So it's not as if it goes to 75 or 90%, where it's more likely than not to happen. That would be unacceptable. But yeah, at 500 would be when we would typically say, I think you should really stop and not give any QT prolonging drugs, and then fix the other things that you can do. So you top up their K and their MAG, and just avoid any further precipitants. Because if their QT is greater than 500 and they've got a second insult, so they've got low K or low MAG, or they get another drug, then what happens is the heart becomes more irritable, and that's where you get what are called after depolarizations, where the heart just decides to start beating on its own, and that's what degenerates into torsades, especially if they're bradycardic.
Perfect, that makes sense. He had a second follow-up question. If Maxran is already given, would giving Haldol in addition significantly increase the risk of extrapyramidal symptoms like EPS? Is there a time interval between each med that would be considered safer? Yeah.
Well, so the way I would answer that is to look at how often we would normally dose Maxaran, which is Q4 to 6H. And so if I had given the Maxaran, I wouldn't be giving the Haldol until somewhere in that 4 to 6 hour mark. The other thing that you can consider, now realize this becomes a bit more polypharmacy, is that you can also pre-treat the patient with 25 to 50 milligrams of diphenhydramine to prevent any further dystonia, because dystonic reactions could be treated with either Benadryl or Cogentin. So if you were going to give Haldol, you could also pre-treat with diphenhydramine. But again, recognizing that that's a lot of medication to put in the patient, and you've got multiple QT prolonging drugs on board as well. So one of the other ways, I know I mentioned at the beginning to consider, using metoclopramide. The other way to look at it would be use something other than metoclopramide, because then if you're going to use Haldol, you don't have two dopamine blocking agents on board.
Perfect. And I'm just going to ask one final question, and I think that would be it. And just, actually, Lynette just asked a quick question. Have we been seeing an uptick in pediatric acetaminophen overdoses given the shortage of commercial liquid peds Tylenol? So people are using adult Tylenol and trying to crush it and dilute it and so forth.
That's a great question, Lynette. The short answer to that is yes, that's actually happening nationwide. All of the poison centers are collaborating with Health Canada on this very thing to upload their data to let Health Canada know, so that Health Canada can follow it and also provide advisories. So yes, each poison center has actually seen some increases because of this. And this you could change acetaminophen with any other drug, and if you start putting it in people's hands to compound themselves, there's going to be mistakes.
Makes a lot of sense. I just have one last question, and then we'll close the night. So just when it comes to alcohol withdrawal, typically what we all tend to use is the CWAS score, just to quantify the degree or severity of the alcohol withdrawal. And then that kind of, typically if your COA is less than 10, you feel safe to discharge, is what classic teaching. But the issue with the COA score, as we all know, is that the COA score is so subjective and can easily be skewed. So it depends heavily on the nurse who's doing the scoring, as well as how experienced the patient is. If the patient is an alcoholic who's fishing for more benzos, they know the questions that are going to be asked, and they know what answers they need to give to get a higher CWA score, so that they can get more benzos, they can stay longer, or potentially get transferred. So if you feel in your head that I clinically don't feel like your CWA score is that high, but the nurses have documented a very high CWA score because of they're just answering the direct question that's given. Is there how do you approach that situation? And then from a medical legal perspective, what's the risk that we take, and how do we mitigate that risk when we're discharging a patient because we don't feel that they're in that severe withdrawal, but they're documented to have a high CWA score?
Yeah, really good question, Asim. And so, yeah, you and I were talking a little bit about that earlier. And so I'll start with two things clinically. One is you can't fake tachycardia and you can't fake sweating. So if those things are present, then the patient is probably telling you the truth. The second thing is that these if you're concerned about a discrepancy between your CWA and the nurse's CWA, then stop what you're doing and go back and reassess the patient, because there may be a medical reason. As I mentioned earlier, you need to ask why did they stop drinking? Maybe there's an infectious etiology, or there's pancreatitis or something like that. Because if those are the cases, then absolutely they need to be sent in for further workup. Then the other thing would be, yes, there definitely is some subjective components to this, but there's also some objective findings as well, like the tachycardia and the sweating. And are they ambulating? Can they eat and they drink? what's their walk, what is their walk test like? And so there's a few objective things that I think you can do with respect to that as well. The other things that I'll say is that in terms of treating with benzos, these are ones that SCM's default used to be Q1H, and you can go in and change that to whatever you want. And so I find that a discussion with the bedside nurse to say, look, you have my permission to dose this person every 5, 10, 15 minutes as needed, or you may have to go in and actually do that yourself to make sure that they get enough. And then at the end of the day, if there's no, intent to harm self or others, and they've actually got good follow-up, and you've documented there's actually objectively things that are better, then I think you're actually well protected. Because you're absolutely right, Asim, and this is not any discredit to the nurses whatsoever. It's just that they're incredibly busy, and sometimes taking a few extra minutes to sit down and assess the patient yourself and do your own SCUC can be helpful.
Perfect. With that, I just wanted to say thank you so much for this incredibly useful presentation this evening. It was useful. I'm sure I speak for everyone when I say it was very useful for all of us for our clinical practice in urgent care. I also want to thank all of the participants that attended today. We had an incredible turnout. We had at the peak almost 40 participants, which is a fantastic turnout for urgent care rounds. Thank you everyone for joining us today. I'm going to send out the link to the recording of today's presentation so you can review this at your leisure later on, as well as Dr. Yarema's email address if you have any follow-up questions. Thank you.